everybody, or good afternoon, depending on your time zones if you've joined us from the West. I'm Brian Rush. I'm very pleased to be your moderator this evening. I have been fortunate to have a very long, successful, satisfying career in mental health and addictions with the Center for Mental Health, Center for Addiction and Mental Health in Toronto, University of Toronto, where I'm still affiliated, and was very honored, pleased several years ago to join the Homewood Research Institute scientific team, where I continue to support this work with close colleague Jean Costello, who's joining us tonight on the panel. And without further ado, I want to just start the process by giving an important land acknowledgement to open the evening out of deep respect for those who were here before us. We'd like to begin the evening by acknowledging that the HRI offices are located on the traditional lands of the Anishinaabe, Arawandaren, Haudenosaunee, and Métis people, and the treaty lands of the Mississauga of the Credit. Most of us are settlers whose access to this land is rooted in a history of colonization and occupation. We acknowledge the living trauma that our history as white settlers has created, and as people working in the mental health field, we understand the deep impact that these traumas can have on current and future generations. HRI supports the Truth and Reconciliation Commission of Canada's calls to action, and we are learning ourselves how to be more inclusive in our research and everyday practices. If you have suggestions for how we can do better, please contact us. We want to do our small part in the larger effort to promote reconciliation and healing. Miigwech, and thank you very much. Thank you again for joining. I'm going to start with a few housekeeping things. Let me start with an overview of the session. Tonight, we'll explore the value of measuring treatment progress, long-term outcomes for people accessing mental health and substance use services. We'll discuss how progress monitoring enables timely improvements to treatment, using examples from other areas of the healthcare system. Finally, we'll share information about work underway to advance these efforts in Ontario. So what is HRI? HRI, Homewood Research Institute, is a national charity dedicated to research that transforms mental health and addiction treatment in Canada and around the world. I'm honored to work there together. We work with some of North America's most influential scientists, researchers, and clinicians in 4 priority areas: trauma, addiction, digital innovation, and evaluation. Through these HRI talks, through this series, we hope to connect you to the meaning and impact of research on our daily lives. We want to empower the public with new knowledge about mental health and addiction research and build hope for the future. For tonight's talk, we have close to 250 people registered from across Canada, and we are also pleased to welcome international guests from the UK, the New Zealand, and elsewhere. Bienvenue, welcome. Housekeeping. The format of tonight's session involves a moderated conversation with our panelists, which I will introduce shortly. This will last about 30 minutes. Next, we'll invite questions from the audience for approximately 20 minutes. We'd very much like to hear from you and invite you to enter your questions in the Q&A at the time. You will find this button on the panel at the bottom of your screen. We do not have for those familiar with Zoom, we do not have a chat feature, but there will be a formal Q&A panel button on your screen. If at any time during the talk you or someone you know feels as though they would like to reach out for support, we encourage you to visit Wellness Together Canada at wellnesstogether.ca, where you can access 24/7 mental health and substance use support. And if necessary, you can reach out and we'll repeat that for you. So our sponsors are in 2 broad categories. First, I'll introduce our corporate sponsors. HRI Talks wouldn't be possible without the support of our corporate sponsors, CIBC and Fusion Homes, and our feature sponsor for tonight's event, KPMG. KPMG is pleased to be tonight's feature sponsor. They have been a funder and supporter of HRI's work related to tonight's topic on recovery monitoring. And as a corporation, they have demonstrated how businesses can lead in the mental health and substance use space. In 2017, they recruited a team member as Canada's and KPMG's first Chief Mental Health Officer. This is a really important development. This is a stellar example of the leadership role that corporations can play, and I understand several other corporations have followed suit since then in respecting that initial work. Then, as a sector sponsor, I'm so pleased to introduce the Canadian Centre on Substance Use and Addiction as a sector sponsor for tonight's talk. And we are also pleased to have CCSA's CEO, Rita Notarandaran, join as a panelist today. Rita has had a long career as a senior leader in the substance use field. She brings a system-level policy and research lens to the conversation tonight. I've been a long-standing friend and colleague of Rita's for many years, and I'm so pleased for you to join tonight, Rita. Thank you so much. The other panelists are two. Dr. Kim Karas is Vice President, Innovation and Transformation at the Royal Ottawa and Associate Professor at the University of Ottawa. As a clinical psychologist and researcher, she brings the lens of clinical researcher to the conversation. And Kim and I have worked together on many projects, and I'm so pleased to have you join us tonight. And Dr. Jean Costello, Director of Evaluation at HRI and adjunct faculty at the University of Waterloo. Most of her career has been in evaluation and research with a focus in substance use, and she brings an evaluation lens to the conversation. Again, Jean and I have worked very closely for the last few years and have got to know each other well and really benefit a lot from her wisdom and watching her do her work and working with all the staff there. So welcome, Jean. Welcome, everybody. So I think we're ready to go. I've got, just for the audience information, we prepared a few sets of questions to start off the conversation. And we've organized the process. I'll ask the question. We've identified already one or two people in the panel best positioned to answer. And we'll follow this process for about another 20, 25 minutes. First question. And I'm asking Rita, my dear friend. We've been working in the substance use field for a number of years. What have you learned from the people and organizations you've been working with? That's a big question. Rita.
That's a large question. Thanks, Brian. I've also worked in mental health, by the way, for over 20 years. So I have experience in both areas. I've learned that we've come a long way, but I've also learned that there is still much work to be done if we're going to achieve parity when it comes to attention to, focus on, and investment in the substance use field. So where are we today? We had an ongoing issue with the opioid crisis. Then along came the pandemic. Combined, these two crises have really shone a spotlight on the cracks that we had already been dealing with, those of us in the system. The current situation has pushed substance use and mental health needs to the forefront and has also highlighted the relationship between these two. Frankly, I'm really hopeful about this overall increased attention. And at the federal level, we now have a minister that's focused on mental health and substance use. And this really points to the recognition of the significant need in these two areas. Not to mention the fact that we now also have 6 provinces with a special focus at the highest levels on both mental health and substance use. And to me, this gives me hope. Speaking about the need and the work to be done, we have done leger surveys together with the Mental Health Commission of Canada for over a year now. And we know a few things. We know that there has been an increase in alcohol and cannabis use during the pandemic. In the general population, we know that around 1/3 of those surveyed reported using more alcohol. For those with a substance use disorder, that number goes from 1/3 to almost 1/2. We know that because we measured it. We also know that just 1 out of 4 or 1 out of 5 of people with problematic substance use or with current mental health symptoms have been treated since the pandemic began. Also, as I mentioned earlier, the pandemic has magnified the cracks in our system. The Leger surveys gave us some data on what was happening, but we have also learned all the things that we do not know in the field compared to other areas of health. And there's really a lot of information gaps, and it's really hard to answer that question. Are people really getting better? CCSA collects data on publicly funded bed-based and non-bed-based treatment services in the community, and we've been doing this for years. But we know there's a need for better data collection in the use of community-based substance use services. And though our project is collecting data on community treatment, it's the only source of information on publicly funded community services for substance use treatment in our country. And even though this is good work, we do not have all community-based treatment services as part of this initiative. And though it is providing valuable information on the number of individuals that access these supports, it doesn't include information on the quality of those services or the outcomes. It doesn't answer that question of, are people getting better? Now, don't get me wrong, our national initiative on community treatment data does give us valuable information, but we need more. We need to know if what we are doing works, if the treatment is safe and effective, and what is happening when people who use drugs seek help. But we also need to measure the experience at each stage of the person's journey, the assessment, the screening, the brief intervention, the referral, in essence, the overall management of this chronic disease when it is a chronic disease. By putting a magnifying glass on all of this through data, we can better understand what is going on, and we can improve the person's journey. We can focus on the quality, the range, and the accessibility of those services and supports in Canada. Now, I have zeroed in on the data and the lack of information, but that's not my only concern. When I talk about doing more, we need to do more when it comes to community bed-based services. There is also a lack of oversight and regulation of privately funded community bed-based treatment in some parts of our country. Except for Alberta, where all community-based treatment falls under one piece of legislation, there is little oversight for treatment in privately funded community facilities. I am not at all commenting on the care being provided. I am simply saying that there is no government oversight of these facilities. In fact, we really don't know how many exist in Canada. I encourage you to read this week's article on one of these facilities in Winnipeg being put on the auction block while patients who paid $26,000 are receiving their care. Why am I mentioning this? Regulation and oversight contribute to better outcome monitoring, improvement efforts, and greater information on quality. Once we have this data, we are then better able to answer the question of whether people are getting better. And one other key issue that I would like to mention that is key to all of this: nothing about us without us. I have seen strides in this area and more is needed here. For programs and policies to be effective, we need to engage people with lived and living experience with substance use disorders and mental health issues in developing and monitoring the services that they need. And this engagement needs to be meaningful if we're going to improve. So to summarize, we've come a long way for sure, but we still have a lot to do. We need better data. We need a comprehensive system that better screens, diagnoses, and treats people, and that monitors how people do with treatment and not just how many people are using the services. We need oversight and regulations for all community treatment facilities to make the system more accountable and responsive. And we need to engage with the very people using the services so that they're contributing to the solutions with all of us. So with all of that, I've learned a lot and I am hopeful. Thanks, Brian.
Wow, what a great answer to such a big question and a good start for today. I'm going to come back to you in a second, Rita, with a follow-up question. But let's just check in with Kim. I mean, is there anything to add into that like great opener? Go for it, Kim.
No, I think it's fabulous and really focuses on the system level and how important those changes and what's going on at that system is going to help drill down to change what we see in our everyday practice, either what clients and families experience or what we experience as providers. And I think that's why it's important. It's not just about collecting data and collecting information. We're going to get into this later, I know, but just to plug now, it's how we use it and whose data it is. So if we're going to be partners with, which I hope we are, as a key tenet of what we do, that our clients and families are partners in the work that we do and in what we create, and that we're not doing this with them, or sorry, for them or at them or to them, but alongside our clients and families as equal partners for our work, that it's also their data too that helps them drive what's important to them. What changes are being, how's their processes going, what is meaningful, and how can they use that information to help guide what their goals are and their next steps, and how we can help as providers do that. So I think it's not just gathering it, it's what we do with it, how we use it, and who owns it and what it's for. I think it's really important. And so I've learned that along the way. And the other thing I've learned is the importance of looking, and I think we've seen this a lot with COVID, and I'm always remarked on just how far we've come with this piece is just the different sectors that have worked together for various things, for various challenges that we've all tried to overcome: the education system, the community system, the hospital system, across all sectors and services, public health, et cetera, and how those sectors that have come together to address the COVID issues and other issues, we should really leverage that intersectoral collaboration to help drive this. I've learned a lot from working outside of the sector that we typically work, and we really need to do that if we want to see big change.
That's a great segue into a follow-up question I have for Rita, because I got a feeling a lot of people who've tuned in might be surprised that we don't actually know if people are getting better. Like that, isn't that an interesting question for people to pose when they're thinking about, supporting people who are going into treatment or thinking themselves or just reading about it. So my follow-up question, Rita, doesn't what we're describing here, whether it's about data systems, whether it's about accountability, or whether it's about how we use the information that Kim added, don't we have this in other parts of the healthcare system? Like, is this not a bit unusual to have this gap here?
I think Kim touched on it, and absolutely, this does exist elsewhere. And we need to look at other sectors. That's one place, but we also need to look at other chronic health issues and how the system is dealing with it. Substance use is far behind other health conditions when it comes to screening and care by our healthcare system. Why I said at the beginning we need parity. I often hear that mental health is the poor cousin of the healthcare system. And I have to say, though mental health and substance use systems are lagging behind, substance use is, you could probably say, the third cousin twice removed from the healthcare system. Years ago, CCSA, together with key partners in our system, like the BC government and CAMH, came up with recommendations for system changes. These recommendations included, among many things, researching and compiling national data, identifying and adopting evidence-based practices, measuring and monitoring. Does any of this sound familiar? That was in 2008. We are now in 2021, hopefully, and finally getting somewhere. And I'm going to remain hopeful. Substance use and mental health issues are chronic conditions like other healthcare conditions, but they affect more than just the healthcare system. So when we make progress here, we make positive change in other sectors of society like housing, economy, criminal justice, education, and Kim touched on the other sectors. More recently, a previous federal minister talked about their frustrations with being able to get daily and weekly updates about infectious diseases across the country. Yet trying to get a handle on the recent number of opioid-related deaths was a huge challenge 5 years ago. And we have to ask ourselves why. We were getting daily and weekly updates on infections, but we couldn't get numbers at the time about opioid-related deaths. And beyond hospital data, as I mentioned, we don't really know how many community services or even treatment centers there are. How many people use these services? What is the waiting time? We do not know what works, and we do not know what doesn't work. So let me give you this example for us to think about. The media tells us that COVID is delaying elective procedures up to 2 years. A lot of us are talking about this. We have people around us that have cancer. I'm one of those people. What can we say about substance use treatment? We reduced services and community-based bed numbers at the start of the pandemic to comply with public health measures and social distancing. Do we know the impact this had on access and waiting times at a provincial or national level? Are we delayed by 2 years, 1 year, 5 years? We don't know. How do we ensure that when people who use drugs want help or advice, they know where to go, like to their doctor? Does their doctor deal with them, assess them, and screen them in the same way they do with other illnesses, such as cancer or COVID? All I am saying is that we have examples when we look at other health conditions and other sectors of what could be in place and should be in place. The whole process has to be looked at and properly supported by the parts of our system that deal with, screen for, and manage all other health conditions. We know what some of those systems are.
Awesome. Let's shift from we have a problem to what's the solution. I'm gonna turn to Kim and then over to Jean, and I'm also watching our time to make sure we have our allotted time for questions. So first to Kim and then over to Jean. So we have the problem, we know the problem, we're just describing it here. What are some strategies that might serve as solutions to help move us forward? How do we do better?
So, I mean, if we're framing it as a problem as what, I mean, there's lots of different problems that we've talked about today, but one I want to zero in on is this problem about data and using data to actually guide how we're doing, what we're doing, and to demonstrate the good work that is happening when it's happening. So one of the things I think that we are doing in certain sectors, in certain sectors of healthcare for sure, and that it is so ripe for use here in the substance use sector, and there's been lots of evidence to support that, is the principle of progress outcome monitoring or measurement-based care. And I think part of what we often think of is when we hear words like measurement and we hear words like data, it sounds like research and evaluation. And while it will give us evaluation, it will help us understand and generate knowledge. Measurement-based care, as we know it, is actually considered a clinical intervention. It's part of our work. It's not separate. And I think that's actually one of the biggest reasons about why these things don't happen, is because we separate data collection and evaluation from actual the clinical care. And once you can bring them together, you can get really good outcomes. You know, we've heard from Rita and you, Brian, and I know Jean's going to talk about it after me, that we need to ensure and demonstrate that the substance use and mental health care system and services have value. We need to demonstrate their high quality, their evidence-based, they're effective for whatever outcomes are important for the people that we're serving, and we need to demonstrate benefits. And when we look at measurement-based care, which I'll explain as the use of tools or measures to assess people's response to care, and it helps us alongside the person receiving care to make decisions about the next step of the treatment based on responses to those measures. So think about other parts of clinical medicine. Could you ever imagine that we would monitor hypertension without measuring blood pressure? Would you ever imagine we'd monitor diabetes without measuring hemoglobin A1C, different blood tests that we would use? Without those measures, you can't do quality care. So why isn't the same true for mental health? Why isn't the same true for substance use? We've been really slow in many areas to incorporate those measurement-based care into our sector. And if we do, it's been shown to improve outcomes, improve quality of care, improve engagement in care, retention in care, better detection of when people are actually doing better or when people aren't doing as well, which then can help us course correct or guide us along with, of course, driven by the clients in terms of what's those next steps. It improves, you know, more accurate judgments and really that personalization of care. It gives us the precision to help make appropriate and accurate and helpful clinical decisions. that we wouldn't have otherwise.
Awesome. So there are things that we can do. I want to shift to Jean. We can do, and we're doing things. I want to shift to Jean, and with Jean, I've been a helper looking to other parts of Canada and elsewhere around the world. Like, what have we learned? And then from there, what have we been building to do better?
Yeah, so I think Kim summarized that first question really nicely. So maybe I'll just touch on what we have learned then, Brian, and what we've seen in other parts of the world or other parts of Canada, maybe specifically. But there is kind of a patchwork of providers and sector and people within the sector that are doing good work in this area, I would say. And we have the opportunity to learn from those experiences, really. And Brian, you yourself know, being highly involved in the work at CAMH and some of the funded work in Ontario to build a system and test it out, see how, operationally, how can we collect data from clients after they leave treatment? And what can we do with that data? And how powerful is that data in terms of being able to demonstrate how people have improved, being able to demonstrate accountability as a sector? And I think that we can look at those examples, and we have looked at those examples to see how we might apply this in other sectors. And the latest example, I think, our work with Homewood to really build something, learning from all of that previous experience, but really build something with Homewood as a partner to do this, a standardized way of collecting data on progress outcomes and longer term outcomes. And that ranges from, reductions like symptom level outcomes. Have we seen reductions in symptoms, improvements in skill attainment, that kind of stuff, but also, those more functional outcomes that the clients and the patients themselves really seem to be their goals of treatment. And that's around, improved relationships, improved quality of care, returning to work in some cases, and going back to their daily lives in some cases, whatever that may have been for them. So I think there's a lot of examples. There are some examples that we can look to, and certainly lots of lessons that we've already learned, but I think that we can continue to learn those lessons and apply them in different contexts, and then of course learn new lessons in those contexts, in those new
Well, we have learned a lot. There is a lot going on in Canada and elsewhere, but you're right, it is kind of patchwork. Give us a brief description of what has been built at HRI. And what we're trying to bridge in and build out into other parts of the system.
Yeah, so in about 2015, I believe it was, we started working to implement a system, develop and implement a system with Homewood as our partner to collect data from clients, with clients, essentially informed by clients, I should say, about what outcomes and what types of data are important to be measuring to determine their success throughout treatment. And so it was really informed by people with lived experience themselves in terms of what outcomes were most important to measure. And working with Homewood, we developed a system where we had a standard approach. We have a standard approach to screening clients and patients as they enter treatment, moving towards kind of a progress or midpoint measurement, a discharge measurement, and then longer term follow-up once the individual or the person finishes, in this case, a residential treatment program or an inpatient treatment program, but collecting that data repeatedly throughout their journey to be able to understand how their progress ebbs and flows throughout that course, and maybe highlighting in some cases or identifying opportunities to intervene with those individuals, or as a group, to identify where those touch points are when people really seem to be struggling and may benefit from a booster program or some kind of intervention that may help direct their course. So with that, we've developed a model at Homewood that presumably could work in other settings, but noting that there's probably adaptations and changes that need to be made to accommodate the uniqueness of those different treatment providers. So in other hospital-based programs, in other community-based programs where they may not have, in some cases, the resources to support such a system, we'd have to be able to really disentangle some of the challenges there and identify what some of those supports might be needed to implement a similar system in that case.
Yeah, that puts you on the spot to describe a very complex and long-term project in less than 2 minutes. So good job. I would just encourage people interested in more detail. They can follow up with Jean or I or through the HRI website. Rita, I'm going to let you bring us home by taking us back up to kind of the system level. What's needed to kind of like build hope in this area? Like bring us back to what's needed in terms of moving all this work forward at the system level.
Maybe I could focus on where the hope comes from and maybe summarize what's happening at the national level. I want to repeat that there's momentum in the system to make changes now that substance use and mental health concerns are on the rise. I mentioned before that we measure this through our polls and have the evidence for action, and through the work of others, we now have this on the national agenda. We now have a federal minister dedicated to mental health and substance use. And as I mentioned, and we have 6 provinces with ministers, associate ministers of mental health and addiction. I know there's a lot happening at the PT level, but I'll focus on the federal and national level. The Liberal platform includes a commitment to quality and evidence-based standards for treatment addressing substance use. That is things that are based on what we know works, what the evidence is. More specifically, the new Canada Mental Health Transfer will provide $4.5 billion over 5 years to the provinces and territories. The platform that I'm referencing speaks to the introduction of a comprehensive strategy for problematic substance use and to end the opioid crisis, looking at standards for substance use treatment programs, supporting the development of a distinctions-based mental health and wellness strategy with First Nations, Inuit, and Métis peoples. It also promises to scale up virtual care services. So as to the national level dialogue, all people, all pathways is really the phrase we must all embrace when it comes to substance use. We need to address the stigma in our systems of care towards people who use drugs, and we have to develop policies that see substance use health as a priority. CCSA is working to address this stigma together with key partners like CAPSA. And so hopefully we have the leadership, the political will now, and the support that the sector so desperately needs. And in addition to working with HRI, CCSA is going to continue to champion data collection. We're currently scoping out the current landscape for standards on bed-based community treatment to inform a way forward that improves quality of care. We're continuing to work with the Mental Health Commission of Canada to develop operational guidelines for integrated mental health and substance use services. And I want to reiterate that we are moving in the right direction. You know, the saying with crisis comes opportunity. We have 2 crises, opioids and the pandemic. And this, what we call this twindemic, has shone a spotlight on the existing cracks, and it has exacerbated the problems that we are experiencing. There's great opportunity for substance use and mental health, and for people with who are experiencing the harms of substance use. Thank you.
Okay, recap. We defined the problem pretty well, that we're short on data, short on accountability, and short on actually how to use it. Kim helped us really bring it down to like, how do we use this to support the work with patients, with people coming for help. Jean gave us a bit of an overview, the national level. There is things underway nationally and internationally, and we've built a pretty good system that others can learn from. So that's a recap. I think I'm going to turn it over to our participants for questions. I click the 3 little buttons down below and I get kind of Q&A. So I think that's how it goes. Maybe there's other helpers here can make sure everybody knows how to do do the Q&A. But thanks so much for a great start. And let's see what people would like us to respond to.
This is Becky, Communications Coordinator for HRI, and I'm just looking through all the questions now. They're actually coming in pretty quickly, Brian. So we have some really excellent questions. I think maybe the first one, just to keep us moving in the right direction, someone has asked if you could clarify the difference between evidence-based treatment and patient-centered outcome research. And the comment is that this is often misunderstood and these aren't the same. So folks are looking for a bit of clarity.
I think that has Kim's name on it.
I'll start, but Jean or Brian, go ahead. We all do this kind of work. So, and actually I think there was another question I'm trying to, actually, if you saw me reading, I found the question button. So I was actually reading them as we were going through. Evidence-based practice, and then is how we take the evidence that was gathered through various trials or studies or research protocols, and then implement that into the work that we do. And that's often what's used to develop our clinical guidelines and our clinical standards or our quality standards to help guide our work, so that as clinicians or providers, we know what we'd be providing should be able, if followed, to result in good outcomes. The patient-oriented outcome work we're trying to look at is when we implement these evidence-based standards, and if we do this in a standardized way, are we getting the desired effect that we think we should be getting? I.e., if we're providing evidence-based treatment, are people actually benefiting? And I think we owe it to, clients who are in the care system for them to know that the care that they're receiving is resulting in optimal benefit, and also that our programs and services writ large, that not just on the individual basis, but when you look across many individuals served in programs and services every year, if those programs and services are demonstrating that the work that work that they're doing is ultimately improving outcomes. And it doesn't mean that if the work with an individual patient isn't improving outcomes, that there's something wrong with in this case, somebody asked about the therapist or the care provider, or that the client's done something wrong. It's not that at all. It's not punitive. It's actually meant so that we can actually learn what we need to do next. It's supposed to guide our treatment and help do the next piece. So that's what we're talking about when we're doing outcome monitoring, or when we're looking at measurement-based care, using the data saying, okay, we've done this standardized approach, but are we getting the desired outcome? And if not, how does that help us do the next step and course correct our work together?
Got it. There's a lot of questions. I'm gonna just move it. Let's go, Becky, because see if we can get as many as possible. And we'll come back, Jean, if we need.
Sure thing. Another question that's come up a few times. Is there any information you could share that's specific to youth and substance use?
Go for it, Jean.
Yeah, this is a really good question. And I know there are people in the sector that are working with youth and have been doing some good work in this area. So kudos to them. What we have been doing more recently in our work is engaging with some treatment providers. And one is a youth treatment provider. And what we've learned is, I think that we need to be conscious of the outcomes that are important to youth. They may not be the same to adults. We need to be aware of the strategies and the ways to connect with youth. Again, these may not be the same for adults. And we need to be aware of the types of tools and measures and the ways we ask questions with youth. Again, might not be the same way we would do with adults. So I think there's some good work happening within the youth sector, but I think that given the demographic and given the differences between the adult and youth populations, some of the ways that I've described, we need to be aware of those differences when we're looking to implement something similar like this.
Yeah, I'm pleased you mentioned the differences in the way we ask questions and the timing, because I learned many years ago that just building trust with youth can take longer, and so there may be maybe kind of more than 1 or 2 or 3 sessions needed to collect the information you want and have that conversation. So pleased to mention that.
Brian, if I could add to this,
Please, Rita.
Brian, I think perhaps the person who asked the question could get in touch with me, because for 3 years we worked with youth in Alberta and in BC, specifically with Alberta Health Services and Foundry that looks at integrated mental health and substance use services. And we have a method of co-design that we have used to arrive at what did the youth want and the parents and the service providers. And for each of the provinces, we were able to develop 4 tools that we are working on now with each province. And one of them is a handbook for parents that Foundry just released, I think it was a week or 2 ago. So these, again, supporting what Jean has said, it's taken us 3 years, developed the trust, but then we co-designed what exactly is required by the youth, their parents, and the service provider. And it was all with the intention of retaining youth in treatment, if that was what their intent was and if that was what their goal was.
Yeah, thanks, Rita, and also the offer for people to reach out to you. And thanks for the shout out to Foundry, which is one of the leading organizations in the Youth Hub integrated youth services across the country. And they've developed common measures across many of them. That's what you're referring to. So thanks for that. Okay, Becky, let's give us another one.
Sure thing. Another actually really good question here. How can we, the patients who receive regular mental health therapy, help to make systemic changes that would capture and use good data? There are millions of us.
Anybody want to take a shot at that one? It touches on the measurement-based care piece a little bit, Kim. I don't know if you want to go there.
I think the most important driver to changing what we do is having patients or clients or people who are affected, people with lived expertise, help drive that. We cannot underestimate just how powerful it is to do that. So one way I'd suggest is, how do we engage as partners in this together? So that it's not, providers alone or people with lived expertise alone, but it's forming that the coalition and the group and figuring out how to do that, helping overcome some of what those obstacles are, helping us work together to figure out, if you were going to implement this, what would it look like? What makes sense if you're going to implement the system to get data? And then of course, how do you use it? What's it used for? Given that it's the data of the people with the lived expertise, is not owned by anyone else. And how do we do that? So I think it's really that call for action from the lived expertise groups, and bringing it forward to say, we want this, we need this, and please do it with us. My thoughts.
Yeah, great answer. And Becky, I'm looking at the questions here too, and obviously trying to get as many of them in. I really like Carolina's question around what are we doing at the front end? And I don't know if you want to go there, Becky.
Yes, the question is, you mentioned that the data are mostly collected once an individual has entered the system. What initiatives are being implemented to help improve access to services to begin with? How is data being leveraged at this entry point or pre-entry point more accurately? And I don't know, Kim, this might be well suited to you.
I think Kim and Rita touches on the rapid access review we did. So maybe both of you can go in there.
Yeah,
maybe Kim first on the system, the Champlain model.
Absolutely. So, and there may be some folks who are here in the audience today who know about this. So one of the largest issues that come from our client and family partners is not knowing where to go for help, or needing to end up to go to the emergency department for help, or trying to get help and really being faced with silos in an uncoordinated system. So one of the things that we've done, and actually with help from Brian, and I think Gord Garner's on this call here, I see him, and some folks from Ontario Health are here too, is launch what we call Access MHA, which is a regional coordinated access system for mental health and substance use. And it started in Champlain region here in Ottawa, and our outside our surrounding areas, and is now scaling up due to its success. And it's first of all, 2 key things. One, it's at the leadership table are people with lived expertise. It brings together 45 to 50 agencies across the mental health and substance use health sector. And it also incorporates peer support and peer navigation and a step care model. And how do we help do this? How do we know where we work? How do we know if it works? Through measurement-based care. And we use data that we collect from patients, that we're collecting from providers, to help determine what's the most, along of course with the client and their goals and their needs, what is the most appropriate level and type of care for this client, and bringing the care to the client in an integrated way, as opposed to trying to have people shop around, which leads to frustration and frankly to people getting worse. So there are examples, and why that's important. I think Carolina, it was you who answered that, who asked that question, and it's because then you actually know the starting point of people, and you're not then, if you do measurement throughout the various parts of the care trajectory, you just don't know how people are in one episode of care. You can actually, clients and family members can follow their journey throughout the care spectrum and look at how they're progressing or meeting their goals throughout, and what the kind of care that one needed to help them achieve those goals. So really powerful when we start doing this from the front end of the system.
Great answer. Rita, I'm wondering if you want to just touch on the work CCSA supported on, reviewing different models for access to service and just summarizing the research that's out there.
One of the basic things that the research keeps showing, and Kim has touched on it at the community level, but I tell you at the national level, it's system navigation. System navigation continues to come up from the client. System navigation comes up from the family, and proper matching. So it's one thing to have coordinated access that as we do in Ontario, we could see that there's 400 people on a waiting list. But the problem is, are we matching them properly in terms of what they're presenting with the services that are available? And certainly, the issue that I just heard today from a deputy minister was the emergency departments. Someone comes in, they have fallen, they had been using some substances, they hurt their forehead, the forehead is treated, and they're sent home. And this issue of access, the issue of substance use or mental health concerns was never addressed. And therefore, it begins in the basic places that exist for every other, I keep going back, with every other health issue that people present, whether it's the primary care office or whether it's the emergency. That's where we have to start. And sometimes it's basic things like, where do people go? And so I think those things, plus system navigation, I repeat, plus matching of people's needs with the services available.
Got it. Becky, we have 5 or 6 minutes left. Deal us up a real juicy question.
All right, here's a good one. Does your work apply globally and in other parts of the world?
Aha. Good one for Jean, I think.
Yeah, that's a good question. Yeah, and I think it's related to what else is going on globally. So we know there are leaders internationally that are working on developing recommended outcome measures for substance use treatment, and we can look to those groups to inform, I think, what to measure in locally, like in Ontario or locally within our individual programs. So I think there's a lot of cross application in terms of what are international groups doing in terms of measurement of outcomes, particularly for substance use treatment, but also what are we doing locally, and how might that inform more of an international perspective.
Yeah, great answer.
And I know that there's some work in the US too, related to a National Association of Addiction Treatment Providers, really doing similar work, trying to convene kind of those early adopters, or those champions that already exist within the sector, to mobilize and really be at the forefront of measuring and being transparent with outcomes, and then using that data to inform and improve care. So I know there are patchworks again of work, good work internationally, and I think we can have a lot to learn there, and we can contribute to that dialogue, I think, by doing good work here as well, and in the work that we are currently doing.
Awesome. Becky, I don't know if Kim's question is on your list, but it's maybe one we can save for the very end. What else have you got coming for us?
I've got another one here, kind of intriguing. Is there anything in the system that we are not currently leveraging or fully leveraging to advance this work?
Rita, go for it.
Oh my goodness. Do we have 20 minutes? But
You got it. I'll give you a short answer so we can get
short
to more.
answer. There's so much we could leverage, and I mentioned looking at other sectors and looking at other health issues and how we deal with them. But there's something happening right now because of COVID, and that is the whole long-term care system. And looking at examples right there, what did we have to do with the long-term care system? What went wrong, whether it be the PSWs, the wage parity, what could we have done better? And I'm saying, if we look at that system, there's so many answers there that we could now apply to our system, particularly when you look at Ontario, where you have 220 community providers, 220 of those we know about, publicly funded. So I'm saying there's a good example right there of things that we could do for our system just by looking at what's happening with long-term care and COVID.
Awesome. Kim, you want to, well, both Kim and Jean have got a scope on lots of provincial activities, but Kim, do you want to touch on some of those things we can leverage?
Yeah, in addition to leveraging some of the coordinated access work that we already talked about, there are other initiatives to increase rapid access to care through rapid access addiction models, but also looking outside of the substance use world into some of the work that's happening with the Ontario Structured Psychotherapy program that's been rolled out and scaled up in Ontario, where there are through models of network lead organizations and community, satellite delivery sites, models for measurement-based care and standardization of care, and the infrastructure and the data that may be able to be leveraged and used for other types of concerns outside of anxiety and depression, as what OSP does now. And that's really learning from some of that from the IAP model in the UK. And that's another place that we can learn from for progress outcome monitoring and measurement-based care.
Okay, Becky, I think Kim Baker's question is a great one to finish on. It might give everybody a chance for like a 15-second response. So,
all right. Kim's asking, what would you say is the most significant barrier to implementing system-wide progress and outcome monitoring?
You want to go first, Jean?
Boy, good question. Where to start? I think maybe I'll frame it as facilitator. So what has facilitated, implementation at the Homewood example specifically, and that's been leadership. It's been direction from leadership and commitment from leadership to do it differently, to collect outcomes and measure outcomes and be transparent and be committed to learning from it. So I would say lack of leadership in some cases might be, or commitment, and that might be tied to funding as well. So just maybe a lack of funding to be able to commit to this type of work. So there's a few there I would highlight.
Biggest barrier, Rita. Go for it.
Biggest barrier, stigma. I think we've seen this in other areas, so stigma. Then attached to that is political will and investment in the system. Yeah. Sustainable investment in the system. And there's a reason why community services, when I mentioned that, why they experience problems in terms of wages and funding and wage parity in general. So those were the three that I would mention.
Okay, I'm getting a sign to close. Kim, you got 2-second answer. Go for it. Biggest barrier in your experience?
Biggest barrier, in addition to what I've already heard from investments, funding, leadership, the commitment to the system working together to do it, And
Good
even
one.
when it is there, the leadership around that and the technology and the investment in the technology to support it and to actually share our outcomes across and to support those pilots and demonstration projects that have actually found innovative solutions to do so.
Okay, real short kind of wrap. First off, thank you, everybody. We're near the end. If you have any unanswered questions, and there's a few out there, feel free to connect with us. You can get connected through the website, hriresearch.com, HRI Research, one word. Thank you to Rita, Kim, and Jean. Everybody's really busy. Really appreciate you taking the time to join us. Thank you to the audience for attendance, keen interest, and apologize for those where we didn't get all of the questions answered, but please feel free to send them in. So we'll be posting a recording of today's event on YouTube in the coming days, and we invite you to share it with others. I assume you'll get kind of the link through your registration information. We'll also be sending out a brief survey. Grateful if you could take a few minutes to offer any feedback, how we can do better, or what worked for you. There will be a draw. Oh, listen, there will be a draw for a chance to win a small prize for those who fill out the survey as well. That's a good incentive. Finally, we invite you to attend future HRI Talks. You see the goal here is to connect researchers, connect research into the community, and what's this all about, what we do. And if you haven't already, subscribe to our email list, follow us on just about every social media message platform possible, Twitter, Facebook, LinkedIn, YouTube, or Instagram. Like HRI, we're really out there. We'll be hosting 2 more talks before the end of March. The next session is scheduled for January 26th, and we'll be taking a look at the exploratory look at the body's microbiome, the microbiome and its connection to mental health. That's a really good one. And in March, we'll be looking at cannabis and its relationship to mental health. So at this time, I'd like to express our sincere thanks to our sponsors, today's feature sponsor, KPMG, really big shout out, thank you. And HRI Talk sponsors, CIBC Fusion Homes, and to our sector sponsor, a big shout out to CCSA and Rita as the leader of that organization for quite some time, a lot of productive work. Without that sponsorship, HRI Talks would not be possible. So we thank everyone really sincerely for being a part of today's event, and we'll see you next time. Good night. Buon notte.